All right, everybody, welcome to the respiratory system. We're going to begin by reviewing some concepts we learned in anatomy and physiology. Looking at the picture on the left-hand side of our lungs, you'll notice that the right bronchi enters into the right lung, which lies more vertical in descent. The left bronchi enters the left lung, and it's smaller in diameter and slightly more horizontal than the right. Aspirations tend to end up in the lower respiratory tract of the bronchus. And if we were to do a cross-section of the lungs, we would notice that there are made up of bronchioles and alveolar ducts. And then looking even closer to the lungs, we know that the end structures of the lungs are called the alveoli. This is where all the action's happening, where the gas exchange is occurring. So we're getting the oxygen and carbon dioxide exchanged at this level. Looking into our thoracic cavity, you'll notice that the base of the lungs lies in the diaphragm. Blood carrying CO2 is removed from the body when we exhale, and therefore get rid of the waste. We know that the lungs, inside the lungs, they're made up of atmospheric pressure, but the lung cavity itself is made up of negative pressure, meaning that that pressure is less than that of atmospheric. This is why our lungs remain inflated. Pressure, again, inside the lungs, it is atmospheric, and then the pressure around the lungs in the lung cavity is negative pressure. And again, this is what allows the lungs to remain inflated. It's important that we maintain this negative pressure in order for our lungs to stay inflated, and so that we don't end up with a pneumothorax or a collapsed lung. If we do end up with a pneumothorax, for example, if our lungs are disturbed, let's say somebody takes a knife and stabs an individual, a patient, in the chest, and it disturbs that negative pressure area, your lungs would collapse. The patient's lung would collapse. How we reestablish that negative pressure is we would insert a chest tube into that patient's chest. That chest tube would suck out all of the air and secretions into a tube system where we could re-inflate those lungs by reestablishing that negative pressure. So it's important as a nurse that we monitor our patients closely and ensure that, again, that negative pressure is not disturbed and that our patients therefore are not struggling to breathe. Anytime there's any excess fluid in the pleural space, that is definitely irregular and unusual, and it can lead to what's a pleural effusion. Pleural effusions, again, is excess fluid in the pleural space, and these pleural effusions can lead to patients getting pneumonia and other infections due to the excess fluid building up in this space. Patients, we often see this pleural effusions with patients who have end-stage renal disease. Our chronic heart failure patients will have pleural effusions, as well as patients who have cirrhosis of the liver, and sometimes we see it also with cancer patients. They literally are unable to handle the fluid appropriately in their body, and therefore it ends up finding its place in the pleural space. We know that our oxygen and carbon dioxide move in and out of the body via diffusion. Again, diffusion is defined as the spontaneous movement of particles from an area of high concentration to an area of low concentration. So we know that the O2 moves from the alveoli into the blood via diffusion, as well as carbon dioxide moving from the blood into the alveoli via diffusion, and then of course we exhale it and it's out of the body. Now we're moving on to the assessment phase of the respiratory system. When we do an assessment, we want to make sure that we are looking at both sides and comparing both sides. We're looking for symmetry and asymmetry of chest movement. Additionally, we're looking to see if the patient has any struggles with their breathing patterns and whether they're breathing too shallow or whether they're attempting to breathe deeper. We know that the normal respirations for a patient is 12 to 20. And we know that we want to maintain oxygenation or SpO2 above 95%. So we want to make sure that we're, again, when we do the assessment head to toe, we're listening, evaluating, and comparing both sides. You'll notice the picture on the left-hand side shows you literally listening to the left side and then listening to the right side at that same level. And you'll do this from head to toe so that we're able to compare the left side with the right side. And we're going to note any asymmetry or any exceptions to what a normal assessment would look like. For example, is the patient breathing faster? Do they have a fast pulse rate? Is the patient coughing? Is it a dry hacking cough? Is it a wet mucousy cough? How is the patient's blood pressure? Does the patient have a low blood pressure or do they have an elevated blood pressure? What about the patient's breathing pattern? Do we notice any labored breathing or rapid breathing? How about the general weakness or muscle fatigue? Is your patient experiencing any type of muscle weakness or fatigue? And then finally, we want to take a look at the patient's mentation, their mental status. Are they alert and oriented ×4? Is this their baseline? And if they're not alert and oriented ×4, then this might be one of the first indicators that a patient's not getting the appropriate oxygenation. Next, we're going to look at lung sounds, specifically adventitious or unusual lung sounds. The first lung sound we're going to look at are wheezes. Wheezes can be heard with patients who have heart failure, lung cancer, gastroesophageal reflux disease or GERD, and our emphysema, chronic obstructive pulmonary disease patients. Most of the time we can hear the wheeze sounds when a patient exhales. However, if they're having a really severe case, then we can hear them when the patient inhales as well. Wheezes sound like high-pitched musical sounds, and this is typically caused by the narrowed bronchioles and the airway that's trying to get out of that narrowed space and that inflammatory space in there. The second adventitious sound we're going to look at is rhonchi, coarse sounds, and they are continuous low-pitched rattling sounds. People often refer to them as snoring sounds. And we hear these sounds when there's an obstruction or secretion in the larger airways that's causing this rhonchi coarse sounds. Typically, we see these sounds, the rhonchi coarse sounds, with patients who have chronic bronchitis, COPD, as well as patients who have bronchiectasis and pneumonia. Next, we're going to look at crackles, which is snap, crackle, pop sounds, and this is due to the air passing through the narrow bronchioles where there is fluid accumulated in that area. We see these crackle sounds happen with patients who have interstitial lung disease, pulmonary edema, acute bronchitis, atelectasis, as well as pneumonia patients. Next, we're looking at the pleural rub, and this is literally a grating, hard friction rubbing sound due to the inflammation of the pleural surfaces, and we typically hear this on inspiration. Conditions where we hear a pleural rub include any condition where the pleural layers are inflamed and therefore have lost their lubrication. This would include pleurisy, pulmonary embolisms, and pneumonia. We see them on both inspiration and expiration. We're going to move on to looking at what causes the shortness of breath. First of all, any type of pulmonary bronchial constrictions. So if you get a possible foreign body stuck in your trachea or airway, that definitely could lead to a shortness of breath. A DVT that has broken off and traveled to the lungs and thus has become a pulmonary embolus, that definitely would cause a shortness of breath. Pneumonia, collection of fluid in the lungs, would definitely lead to shortness of breath. If you have a lung collapse and you end up with a pneumothorax, that would lead to having shortness of breath. And finally, if your heart's not perfusing appropriately and correctly, this definitely will lead to your lungs struggling to compensate for that lack of oxygenation to the tissues. So heart failure or heart pump failure. Now we're moving on and looking at respiratory and metabolic acid-base imbalances. First of all, respiratory acidosis we're going to take a look at. This is where there's an increased CO2 level and a decreased level of bicarb. Patients who have respiratory acidosis will have rapid shallow respirations. They will be therefore hypoventilating, which will in turn lead to hypoxia. Their BP will be decreased with vasodilatation. They definitely will be dyspneic or short of breath. The shortness of breath will manifest initially in a headache, and if this respiratory acidotic state is continued, the patient will be drowsy, dizzy, and then will continue to become disoriented, may become combative, and semi-conscious, and then unconscious. Patients who are respiratory acidotic will be hyperkalemic. Therefore, you will see that there is dysrhythmias with patients who have respiratory acidosis. Additionally, we will see muscle weakness as well as hyperreflexia. And the patients will continue to complain that they can't catch their breath or get enough oxygenation to their tissues. We see this most often with patients who have COPD, pneumonia, atelectasis or atelectasis, post-op patients who come out with anesthesia, and drug overdose patients. You'll note that the pH will be below 7.35 and the CO2 will be above 45. And again, this is due to the retention of the carbon dioxide by the lungs.